maybe we can just open it up to you and see if there was any high yield points or things you wanted to highlight that we didn't necessarily cover.
Maybe we could just end a minute on the role for an intervention, because this becomes really complicated. And I think that there's a few pearls that are really important. One is, you have symptomatic peripheral artery disease, you do not need a revascularization procedure because of peripheral artery disease. So I always tell my patients, and I dumb it down even, I make it like the corner space. I say, you have stable disease and unstable disease. Stable disease is either asymptomatic disease, no disease, or claudication. You can live your life with claudication and not need an amputation, which means that when you do get it referred for procedure, it's only for a quality of life issue. We've only been able to show that if you have terrible claudication that's refractory to cilostazol and supervised exercise therapy, and you can't complete your daily functions, that's a good time for you to have a discussion about a procedure. But those are a small sliver of the claudication population. And so if you notice that you're sending a lot of your claudications to someone and every one of them is getting a procedure, they're probably overusing the procedures. Surgery, similarly, we don't do a lot of surgical bypass for people with claudication, because the risk of the surgery tend to be often outweighed by the risk of the condition. Now, you can do surgery, and there are people who do get surgery, but it tends to be less frequent. I talk to my patients about that a lot. I say, listen, you have stable disease, you have good quality of life. Our goal is to improve your global cardiovascular risk profile by focusing on the medical therapy. And I love people to do exercise, so supervised exercise therapy, even if you're comfortable with your quality of life. And then some people say, I cramp every time I walk. I don't like to walk that much. I'm a homebody and I like to sit on the couch and my groceries get delivered and I have good quality of life. I say, great. We don't need to do a procedure in your leg. Let's get you on good medication and watch you. If you have a wound, rest pain, ulcer, gangrene, and peripheral disease, you should be revascularized ideally within 2 to 4 weeks. And so we call that unstable disease. So, if you come into my clinic, I saw a woman Friday. She had this ulcer, then been there for 3 weeks. She had peripheral disease. She had diabetes. It wasn't healing. She needs to get to the lab on the sooner side if we're going to try to save that toe. And again, in our business, toes come and go. We don't care about them as much because people can be fully functional. If they lose a toe, we care about feet. If you get disease that threatens your foot, you're a different person because you're going to need to get at least a below-the-knee amputation. You're going to need to either be immobile or with a prosthesis. And we know that your mortality changes significantly post-amputation. So on the internist side, very rarely you're going to send a patient and say, this patient needs a procedure. I'm sending it over to Eric to get a procedure. It's mainly, can you help them co-manage this condition and get them on the right meds and make them comfortable? And maybe that involves a procedure, but that's not typically the first line thing. But if you run into a patient and they have an ulcer on their foot and there's suggestion of peripheral artery disease, they have a risk factor like diabetes, that warrants an immediate urgent consult for someone who can do revascularization procedures, whether an interventional cardiologist, interventional radiologist, vascular surgeon, because that patient needs an attempt or a discussion about revascularization on the earlier side to really get them the best treatment option. And we published a really important article recently just talking about the likelihood of getting an angiogram or attempt for revascularization before an amputation. And it was really remarkable. There are people throughout the US that have undergone a major amputation and no imaging of the arteries or attempt at revascularization that potentially could allow them to avoid an amputation, more than 60%. And that tends to be among people who are very vulnerable, like minority race, lower socioeconomic, non-English speaking populations, not in urban centers. And so we have a real problem with this, and it's something that we're working as a community to figure out. But everybody can do their job by identifying when there's a problem as early as possible, and making sure they're connected to someone who really focuses on this condition on the earlier side, so they're offered all the opportunity to save their limb before it's too late.